or good evening even, depending where you are connecting from today. So we are really happy to welcome you here for our fifth series of the webinars in Data Improvement Plan. And today we'll be talking about, as you know, the Health Management Information System. And we know that you are waiting, you can't wait to have that. And we'll be talking with, as usual, experts from WHO, but also from Gavi. And yeah, I would like to send a special welcome to new attendees joining us for the first time, but also for returning attendees that I would like to address our congratulations for their commitment, but also all the scholars in the room following the course with the WHO Scholar Program and all their companies really to support a scholar. So welcome everyone. Please sit comfortably and get yourself your favorite drink. Today I'm having water and I'm happy with that. So you can have a coffee or tea or juice, whatever you feel comfortable with, because we really want you to participate during this webinar. As you can see here, we invite you to open your browser and type www.menti.com and using the code 211236. The code is 211236, and we can see on the desk that some folks are already start to do it, and we can see that Indonesia, Timor-Leste, Pakistan, Malawi, India, and Libya, they start to use www.menti.com and they enter the code 211236 to tell us from which country they are connecting from. So please go ahead, open another tab of your web browser and type www.menti.com code 211236, and you will be using it throughout the webinar to interact with the pool or the survey that you will see on your screen. So we encourage you to go to www.menti.com code 211236 and type the country you are connecting from, and we can see here that India is leading with more attendees who understood the principle of going to another to type www.menti.com and use the code and type the country they are connecting from. Welcome to all those who are listening to us from Netherlands, but also from India, Nigeria, Libya, Ethiopia, Zambia, Timor-Leste, Curacao, Togo, Zambia again. So you are all welcome. Type the country you are connecting from using www.menti.com and use the code 211236. So one more minute left before we start the formal time of our webinar. I know that today you are all excited like I am with the rest of the team. So as the panelists of today from WHO and Gavi. So today we'll be talking about the Health Management Information System, the DHIS2, and we know that it's a subject that is really actual and you can't wait as we are to start. So please do it, type where you're connecting from. So it's 2:00 p.m. in Geneva time. So we are starting officially our webinar. Thank you for using the menti.com website to enter the code 211236 to interact during the webinar. We encourage you to do so. Today we'll be talking about Health Management Information System. So we start formally our webinars today. So we're really happy to have you here. For those who are coming for the first time, you're really welcome here. But returning attendees, showing their commitment to the series of webinars offered by WHO, but also those taking the course at the moment, the scholar and the companies who are there to support them. So welcome everyone. Today we'll be having Jan Brevendong from WHO Geneva, but also Karin Gashen from Gavi Geneva too. And you will hear from them really soon. While you are continuing to type where you are connecting from, and we see that Pakistan is still leading. Thank you all attendees from Pakistan, and also Ghana, Nigeria, and India. So please go ahead and use the menti.com as shown in the decks to type the country you are connecting from so that we have a sense of who is in the room. So you are welcome, take your drink and sit comfortably. We start now. We'll talk a little bit about the ground rule of this webinar before we introduce you to the the expert. So let us see like I say, it's the 5th of the series. So your active participation is required. So you use menti.com with a new tab on your browser to respond to the surveys, but also you see in front of you having a Zoom, and then most of you know how to use Zoom. We have 2 features on Zoom that we would like you to choose to participate actively. We really want to hear from you, from your experience. So use the Q&A button box to type your questions related to the HMIS system, but also the chat box to type also your comment about what the experts are talking about, or suggestion, or your own experience, and share it with all. Again, we will be sharing the links for the resources, so don't worry, stay with us. You will have it in the message box. And the second thing that we would like to show you here is you have here on the desk at the moment, you have after the ground rule, we would like to show you where to go if you want to type your question on the Q&A box. So please, Jan, you want to see the next? So here is the message. We invite you, we encourage you to use all panelists and attendees in the message box so that experts and all the attendees can see your comment when you are typing on the chat. Please go ahead and type and choose the option all panelists and attendees. Yeah? And the Q&A box is the one we are showing now on the screen, where you have to click on Q&A and then enter your question. And if you don't have a question and you really see a question that you would like the expert to respond to, please go ahead, use the thumb and click on the thumb and vote for the question, and the expert will be likely to respond to question, getting the maximum of votes. So now, here we are. Now we have the menu here. I will now, I'm excited to turn myself to Jan Grevendon and Karin Gashen from Gavi. So Jan, can you hear me? Good afternoon.
Yes, Alain, thank you. And thanks everybody for joining. Before we start, maybe I'll ask my colleague Karin to introduce herself.
Hello everyone, so I'm Karin and I'm working at Gavi. I'm the Health Information System and the HMIS focal point in Gavi. And I'm so happy and excited to be with you today.
And my name is Jan Grevendonk, so I work at WHO in monitoring. So just to say, first of all, that today we'll talk about HMIS, Health Management Information Systems. Some of you might have seen the agenda and thought that this was going to be about denominators. So it's not about denominators today. We kind of switched that around. We'll talk about the information systems you need to kind of track your program. We'll talk a bit about integrated versus parallel systems, and then we'll talk quite a lot about DHIS2 and seeing it as an opportunity for immunization. Now, I would say it's not because we talk about DHIS2 that this will be the only thing that really can be discussed. So if you want to share your opinion about your country and you don't use DHIS2, you're also very welcome to share that. We just wanted to use that for illustration purposes. In the end, we'll ask you also to share a story of your own, an experience of your own, and actually share with us like what have you done to make the information system easier to use, more useful for people, etc. So anything around what we will be talking about, or any questions that we will try to address, right? So if you can all hear as well and we're all set, let's start with the webinar. Okay, so first of all, share your experience. Like we wanted to give you some ideas about what you can share your experiences about. And these ideas could be kind of talking about your challenges with integration or possible benefits you might have. How can you as an EPI program make sure that the program needs are met within the HMIS, which is often kind of a national system that cuts across programs? How can you achieve better collaboration between EPI and HMIS? How can district use their system for analysis, supervision, review, data quality set checks, information sharing, etc.? Have you had any experience with redesigning or designing forms and entry screens that actually make it more user-friendly for people and reduce workload rather than adding to the workload? Have you had experience with redesigning work of data managers? So now that data managers do less transcription and kind of entering data twice, can we think about more meaningful functions that they could also help the program with? So if you have any of these ideas or things that you would like to share, put them in the Zoom Q&A, and also importantly, like, read other people's questions. And if you like an idea that you see and you would hear more about that, give them a thumbs up, a like, which you can do in the Zoom Q&A, and then we will make sure that these questions with most likes are answered earliest, and the experiences that you want to share with most likes are answered also. All right, so here we go. So I'll start with a few slides and I'll hand it over to Karin. But first of all, like, we wanted to find out from you and the people who were able to connect to Mentimeter, so menti.com. Can you let us know if in your country your system is based on only an integrated health information system? Is it immunization and an integrated system that exists in parallel? Or do you have only an immunization-specific system? So right now, about 12 people have been able to answer that, and it used to be the same, but we still see that in many cases, or for a lot of participants, there are still kind of double systems in place. So you have an immunization-specific system as well as an integrated system that exists in parallel. So we can talk a little bit about the challenges of that, and if that's a good thing, a bad thing, and how can we solve the challenges with that. All right, so I'll give it just a little bit more time. You've been like 250 to connect. 65 people have been able to answer that. So it's just to have an idea, and no worries if you weren't able to answer. There will be more questions later on for you. And this is the next question. We want to find out if you agree about your assessment about the system in your country. Does it collect all the data we need for immunization? Okay. Does it collect the right data? Does it provide good outputs to facilitate analysis? That can be reports, dashboards, all these kind of things. Is it efficient and user-friendly? Does it provide built-in checks for data validation? And do you think that EPI and HMIS staff in your country collaborate well? So the way this works in Mentimeter is that you can actually use the sliders to show whether you strongly disagree or strongly agree with those statements. And as you are finding this out and answering the questions, we'll give it a bit more time because we only have 20 people talking about that right now. So yeah, and there's a certain tendency here, a trend. It seems that starts from the good thing. It seems that our systems collect all the data we need for immunization. So that's definitely positive, at least for most of you. You think that's the case. Only a few that are totally in disagreement with that, but for most of it, it's quite fine. It provides reasonably good outputs analysis, but then we actually get into worse territory. You don't think it's really necessarily always user-friendly. It may lack checks for data validation. And finally, EPI and HMI staff collaborate well. You're not entirely that sure about this collaboration. So Karin, is that matching your experience as well? Or?
Yeah, I think there is a tendency to say that the immunization program amongst all health programs has quite a good system, and all the needed data are available. So this, I think, is conform to what we expect. After, I think, of course, the collaboration with it between EPI and HMIS program is something that we need to all work on together, and we see there is still some room to progress. So let's hope that the webinar will help us to progress on that side as well.
All right. So 100 people have answered. Thanks for sharing your thoughts about that. So let's first start with kind of this graph that I actually used in a different webinar as well, that shows how programs collect immunization data. So you see here kind of there's three boxes. In the left box we have everything that we would consider routine monitoring of program data. And that typically has kind of the facility reports, kind of the monthly reports that come from the health facilities that have, that administer doses, the vaccines used, the session plans versus health, communication activities, cold chain status, adverse events following immunization, and all that kind of stuff that are reported month by month. And within that routine monitoring, you have like a number of electronic systems that are really coming up, not just in the world, but also in Gavi countries. Here we have the health management information systems, the innovation registries, so the electronic registries, and the logistics management information systems coming up. In the middle box, we're not going to talk too much about that, but just to remind ourselves that there's other sources of data that are not from routine monitoring, but that are actually kind of survey-based. So you have periodic, maybe every 5 years, you have population-based surveys to establish kind of, to get you coverage estimates, for example. You can also do facility-based surveys to get kind of more information about missed opportunities, knowledge attitudes and practices, EVM, SARA, TIP, EPI reviews, DQSs. There's actually a bunch of surveys in that group, so we're also not going to talk about that. But finally, there's a final source of information, which is the surveillance data. Surveillance can be integrated, so where we get number of VPDs, so aggregate surveillance, or it can be case-based. So where for each disease, you make a case investigation report, and you find out what the result is. So that is typically done for polio, measles, rubella, serious AFIs, and other diseases as relevant, like, for example, yellow fever or Ebola, if you're in one of those countries. It typically has identifiers and locations and the outcome, including lab confirmation, and finally you try to get the immunization status. Just to say that we will also talk a little bit about surveillance and how we can use HMIS or routine systems to actually collect these surveillance data during this webinar. So in this webinar, we'll talk about the left box and the right box, but not the middle box. And then outside of the program, there's data from other health programs, other government programs, the National Bureau of Statistics, things like geographical information systems, and even, for example, social media. Why not?
Everything.
Right. Okay, so this is just to kind of, again, remind you of what the immunization routine monitoring and immunization information systems have. Before we go into much detail, I also want to say that we will have a dedicated webinar to one of these things that you see here, which is the electronic immunization registries. So we could have talked about it now, but it would have been too busy. I think we can talk a little bit about it, but let's keep most of the questions and remarks for actually the last webinar in the series on electronic immunization registries. Before I hand it over to Karin, I think, just to say that we have a complicated relationship with HMIS and integration. So as Karin mentioned before, immunization often has like more complete, often better working systems than the newer HMIS system that comes sometimes later. So as you indicated, in many countries, the Ministries of Health and the EPI programs still rely on EPI systems that often are from before the HMIS. However, we know also that change is happening, and even like since we presented this last year, when change was still being debated, I feel like the change is really happening, and we see in most countries that there's a move towards integration and kind of the use of HMIS. So what we would then want to make sure is that we kind of tackle the barriers that are there towards those integrations. And what could be the barriers? First of all, I think in the governance, we see that not all EPI indicators are always included. If a new vaccine is introduced, often the HMIS is much later in introducing that into the HMIS. Even the forms would need to be updated, so there's a lot of coordination needed to make sure that these things are planned first. Sometimes you see a lack of access for EPI staff and a lack of collaboration between HMIS and EPI. And finally, that the review point at district level, which are really often important in immunization programs, they're not well accounted for in the HMIS circuit. There's technical barriers that are about the output that are not always useful for EPI. That before, often if we had a paper-based or an Excel-based system, you know, that is offline, you didn't have the access issues. And with the newer HMIS systems, and especially like things like DHIS2, you can see that you know, the access to that online systems might pose its additional problems. And then there's funding barriers, kind of that, you know, like for an HMIS to work, it really would require all programs to kind of put their eggs in the same basket and really fund that together. And that's, of course, difficult to ask if you're not entirely sure if this will be useful for your program. So these are some of the barriers that we have. What is our recommendation as WHO? So what we see is that in a lot of countries you see something like this on the left side, where you have a DHIS system, for example, or another HMIS on one side, you have an API system on the other side. And what we see is that it really kind of requires a lot of double entry, which we think needs to be avoided, and kind of makes things more complex, needlessly complex. So while not trying to advocate for any specific system, we think that API should align with Ministry of Health norms and standards, and kind of try to integrate as much as possible. But we have minimum standards for that. We say, like, before you do that, you have to make sure that the HMIS system actually corresponds to what you need. And then I'll leave it to
and I was just looking at the question or the comment from Fitwi Meles. I hope I'm pronouncing well, and it was exactly what Jan was talking about. There is the WHO guidelines with kind of listing all the data elements and indicators that have to be integrated within the HMIS system. So it was really timely. So we wanted to speak a bit about DHIS2, and we wanted to know if DHIS2 is an opportunity for immunization program. We wanted also to really acknowledge something about WHO. I'm speaking on behalf of Jan, but also all the partners common in the immunization from UNICEF, Gavi, CDC. We do not recommend a specific solution, a specific tool, a specific platform, but of course we have to recognize that DHIS2 has been rolled out in more than 60 countries as a national information system. And also there is a strong capacity building program that is available in all those countries. So it's why we had to consider it and talk about it, and when there is some guidelines that are out, that we try to make them align with the DHIS2 content as well. So, yeah. Also, we hear a lot about DHIS2, and before focusing on the aggregate part, what we really call the HMIS, a Health Management Information System, we wanted to give you a kind of landscape. DHIS2, with the same name of DHIS2, solutions are used in very different type of piece of the information system. So just wanted to map it. So like that, we are sure that after that slide, we all speak about the same thing. So we'll come a lot on the aggregate data system. At the end, we have also with touch point on the surveillance and AFI. But also now countries are using DHIS2 on their mobile phone, for example, to monitor campaigns. There is new applications that have been out to really help on the management of the program. So you have the system of scorecards, for district level, an application as well called bottleneck analysis that helps you to understand why your coverage could be low. And also within the DHIS2 platform, they use the GIS function. There is interoperability between DHIS2 and the ELMIS system. There is a link also between the HMIS and the CRVS, the Civil Registration Vital Statistic System, with the birth notification. And also now there is a DHIS2 tracker, which is only for individual data and as a function of electronic immunization registry. So you see it's quite wide, but we wanted to make sure that you know that everything is out there, but now we really focus on the aggregate data, what we really use for our coverage data.
Yeah, and I think a lot of you who have, even in countries where you don't necessarily have DHIS2, so I think about Pakistan, so you have an aggregate module in Pakistan, or actually, to be honest, all 6 provinces where you have their own model for aggregate reporting. But apart from that, you're also already kind of thinking about, or you're experimenting with electronic immunization registry. So there's a lot of different modules and things out there. So just to say, when we talk about the HMIS, we often talk about kind of the aggregate part of that system, but it's actually something where we see kind of the limits or the borders kind of being a little bit vague, as a lot of these systems start doing a lot more things than just that.
So now back to focusing on aggregate. So actually WHO has put up a whole complete set, a toolbox of guidelines that you can find. We'll give you the link at the end. And you have to understand that the EPI module is really part of all those other modules. So it was based on what we call all the facility data, so all the data that are out from the point of services. And there is also guidance on the master facility list, for example, also on the cause of death. And is a lot of work that has been done on the data quality component as well. So all of these guidelines have been translated in applications that you can install in your DHIS2 system in a country. So as I said, the data quality review is a very important component, and actually digitalization of your health information system allow you to really more easily review the quality of your data. So there is a set of guidelines, and one of the steps for this DQR is to do a desk review, of all your data. And you can do that, on an Excel tool that exists and is made available by WHO, or if your country has a DHIS2 in place, you can also run that application, and it gives you the analysis, so you can check your completeness, your timeliness, you can easily see your internal consistency, but also external consistency. So there is all the indicators for immunization, but you can also cross them with indicators from the Mother and Child Health Program, for example. So now is like this set is going to be adapted to be used also more easily at the district level. So this will give more power to the district health officer to really check the quality of data within their catchment area.
Just to say, like, all these resources that you see here, you can Google them. I will also put them in the resource box. So if you go to that link first that you saw there, I will put it there. If you go there now, it will not be there yet, but I promise I will copy it in there.
So now for the what we call the immunization module, so there is this guidelines, and there was a question at the beginning, I think, from Fitwi Meles, asking, but which element of data should be included or not included, and WHO have really done a hard job, like, telling which indicators are highly recommended and giving you all those information. So I think it's good to have those definitions and make sure everyone is aligned to it. And beyond the data elements and the indicators is how to use those data. So there is a set of dashboards that give you more opportunity and to analyze the data, and then you try to take the decisions that you need to take. So this module really on the same shape and design as for other programs like malaria, TB, MCH, but really specific for immunization. And another piece that has been added is that for many countries in Africa, I think mainly, they generally once a month export their data to WHO via a format we call RIM. There is a button there that you can just click, and your monthly report for RIM is automatically generated. So this is also accompanied with a curriculum, and there is a training book, and so if you decide to run this training in your country, you will have all the materials available for you. So for example, I wanted to show you what could be a dashboard for immunization. So it's important to note that, because all the data elements have been listed, you will find everything there. And it's not only the coverage indicators, but there is also the supply and the cold chain, for example, the stock availability, every data from the cold chain, from the supply chain that you can find at the facility hotel has been included. Also the data, aggregate data on AFI, for example, if you're doing immunization sessions. So all the elements are there, and then you see these nice visuals and output that you are all, I think, familiar with. And there is another dedicated app that was created with WHO and University of Oslo, is to go beyond just those classic dashboards, is to give you more possibility to do in-depth analysis. For those who used to work with the DVDMC Excel tool, you used to have specific tables for vaccine doses and immunization coverage. You used to have your monitoring charts, for example, and you can do the category of your district according to their performance. So this has been designed for you to still have that that analysis, that output, and in general, EPI program really loves that app. So this is a bit kind of the situation we are trying. So this is only for the Gavi supported countries, so 68 countries. And actually, there is a lot of movement. And in 1 year, we have seen that there is more than 17 countries who have adopted those WHO standards, and they apply them into the HMIS/DHIS2 system. And so it's really moving fast. And the data is a bit like at the beginning, I think we have the same alignment as the Mentimeter at the beginning, where you see now is 10, we don't see properly, but it's like 10 countries now have stopped their parallel system. They're just using whatever is in the HMIS/DHIS2. And you have some countries that are transitioning, meaning they still have the two system, and this is a majority of countries. We have like 28 countries. And some other countries, they are having their own standalone EPI system.
What do you mean with fully integrated?
So fully integrated is that all the data elements that are needed for an immunization program have been all included to the DHIS2, but they are like having that last month of continuing the system, and most of those countries they wait 1st January to stop the DVD-MT. While the other, the transitioning is like, okay, they have a plan to transition, but it's like for 2 years or 3 years plan. It's on a longer term.
Yeah. All right.
So this was all the aggregates. Should we take some question on aggregates?
Sure. So Alain, this would be maybe a good point to get some questions first and talk about aggregate routine monitoring.
Yes, Juan, if there are some questions on the Q&A that we encourage all attendees to use to really ask the question that they would like the expert to respond to. So yes, Ian, please go ahead and we can start by some questions.
Okay, so maybe I can first come back to Fitwe Melis's question. I think you're from Ethiopia, isn't it, Fitwe? So you mentioned that for any government, there might be a competition. Yes, you can only put so many indicators into the national system. And so isn't it a risk that immunization doesn't get all the indicators you need or deserve? So I would say, yes, that risk is definitely there. And in some countries, we've seen that, for example, where not all vaccines are in the HMIS, or for example, DTP1 and 3 are there, or Penta 1 and 3 are there, but Penta 2 is not. So there might indeed be sometimes a competition, and then it's really important to say, well, all of these different vaccines for us are different indicators, and we need them all. I think where we have to be more careful is probably like in how many ways we want those indicators cut up and disaggregated, and we come back to that maybe later. But we have to be careful not to ask too much, because like we see that there's a lot of kind of disaggregation. First of all, for example, by sex of the child, male, female, so that's one level of disaggregation. Then within the age group, outside of the age group might be another one. Then there's countries that want to disaggregate it in, for example, outside of the area versus inside of the catchment area, and that also complicates it again. So you see in the end there's like a lot of disaggregations that are maybe not always necessary, and we also have to be careful about that. So I think that would say about that question. Just a clarification, maybe, what is the name electronic immunization registry in the right side hand of the picture? Dalia Silitonga Aestet. So we consider an electronic immunization registry an electronic system that captures every child and their record individually. So they don't store numbers, but really information child by child, nominal register. So this is something that is really coming up in many countries. And we want to kind of talk about that, but not in this webinar. We'll do a dedicated webinar to electronic immunization registries in a few weeks' time.
I saw there is several questions on the supply chain, actually, on the vaccine management. So there is a question on blockchain. There is a question on It was on another, I don't know, it is gone now. So we didn't include much discussion on that today. As you know, the logistic management information system is a complex information system, and it's complex already on the paper, and even sometimes more complex with when it is digitalized. And maybe on the last webinar as well, it should be mentioned a bit. But so we didn't include this here, but it's true there is some link between both systems to allow, triangulation of information between the number of children you vaccinated and the number of doses of vaccine you used. So this is available in both systems. So if you have an LMIS system, you can ask, for your data to communicate with the DHIS2 system, for example, and vice versa. And after also, another point to avoid confusion is that at the beginning we said that within the data elements that are collected at the facility level, supply data are there, and DHIS2 can be used to as a collection system to take those data from the facility level and to bring it to the district level. But the DHIS2 system does not manage, does not just give you that data, but does not manage it. So this is what I want to add and clarify on the LMIS.
Yeah, and then there's a few related questions. So I think somebody from India asked about the event system and how that integrated in the HMIS, and I can't really find it back now. But to be honest, so the event system of UNDP, that is actually a logistics management information system that is being integrated into the HMIS in India. So that's an example of what Karin talked about, where the logistics system can be integrated or can be part of that health management information system. I think the same person, Dr. Sidalangaya, also asked what are the DHIS2 solutions? What is that? So that's a good, I can't find it here. So what are DHIS2 solutions? I think, I don't know if we agree, but I think within DHIS2 you have three big modules. One is the aggregate system, then there's an event tracker, and then there's a tracker.
The patient level tracker.
Patient level tracker. So all of these three things, they actually do different things. So one you can use for the monthly reporting, one you can use for following up on individual children, and one you can use, for example, for campaigns and surveillance and these kind of things. So it's different modules within DHIS2, just to clarify that.
There was a question on why DVDMT still exists from an anonymous person. Just to say, there is some challenges that Jan mentioned at the beginning. One of the main common from experience challenge is the connectivity. At the district level, it's not all the districts that have access to internet or have the means to support the monthly fees for internet. So the Excel document, you put your data in, and even you send your Excel document with an email, but you keep your data set accessible offline. And while DHIS2 is really working hard on getting offline solutions, so it is already you can have data entry offline if you have an Android mobile for aggregate data, or if you have a Chromebook, it's a specific Android-based laptop, for example. But otherwise, if you have a normal laptop, normal Windows laptop, you cannot, you need each time to connect at least time to time to internet to enter your data, and after also to do the analysis and all of that. So some districts are not comfortable with that, with the internet solution, and until the DHIS2 and University of Oslo will, if they don't solve this offline issue, we still have people using Excel systems. This is one of the reasons. And the second, I say more general reason is about the capacity, the training. It takes a lot of time to train all the country, for example. So it takes resources and time. So it's while we still have other solutions in place. So this, to answer to Ibrahim Kamara, so who can predict the DVD empty life expectancy. Nobody can really predict. It's just that in many countries, I think every year some countries are dropping it. But you know, maybe some country will keep it. It is a choice of the country to adopt the best system for that meets their needs.
And the question was, does this mean that DVD-MT is no longer going to be in use? So that's, we can't predict that, but we see it kind of being replaced in many countries by this HMIS approach. Just before we continue, there were a few more questions about, like, from Olivier Wayne and Alain Kikwaya. Why is there no national or international standardization of HMIS, and what are the traits or indicators that should be used? So we've tried to write those up, and that's actually what Karin showed in the beginning. So there's actually a manual or a guideline that actually has exactly that. So what are the indicators that should be in any HMIS? So I'll put that in the Dropbox. Just also to say that I try to summarize it as well in the handbook, which you have, and in the draft handbook, and which is there also in the Dropbox. I think we should probably continue and take a few more questions later, Karin.
Okay, so we have been talking a lot about aggregate, and we wanted to just give you an insight on the surveillance system. So the surveillance system could be, as you know, used for vaccine preventable disease, but also for many other diseases outside the immunization program. And the system that is facing a lot of fragmentation is quite a complex system, and also, among the even WHO is a lot of units that are leading on the content, on the standard of that system. So now what we have seen, and we wanted to share that experience, is like around 20 countries that already use actually the HIS2 solution for the aggregate data of the surveillance system, and already we think like between 5-6 countries are also using the HIS2 based solution for the case-based surveillance data. So to say when the partner and WHO so that that country are picking up and setting up their own system, they also wanted to make sure that countries have the tools to respect the standards and the guidelines. So now there is a huge initiative to do a bit the same work that was done for the coverage and the aggregate data, now to do it for the surveillance data, and making sure that all the standards are well respected, and we can expect that within 1 to 2 years, same kit, similar kit will be out for surveillance. Also, the difference for the surveillance system, as you know, there is way more connection to do, for example, with the laboratory data when you have to confirm the cases. So it's a more complex part, and you need to have this longitudinal data for each case. So it is a bit harder to fix that and to make this, on a simple solution that can be used on a mobile phone in a very remote area. There is also on the surveillance system, what you can see there, all the alert systems. So some countries, unfortunately, have been facing some very deadly outbreak, and they are putting up in place some alert system. And again, they use that DHIS2 for that piece of the surveillance system. So more to come, I think, in that area as well.
So maybe just to clarify or to add to this, kind of like disease surveillance is then the next big thing. And as you know, right now, a lot of the surveillance data is, it's not, apart from the IDSR, which is probably within the HIS2 or the integrated approach, there's kind of disease-specific systems to collect those data. I think those systems are not quite as easy because, as Karin mentioned, there's a workflow here. First of all, you do the case investigation. You probably have data that still need to be updated, such as the lab confirmation. And it's a huge effort to kind of work with the line lists and upload those and update those, and make sure that even, for example, the districts who detected those cases also get the feedback of that. So there's actually a lot of work to be done. And I think, as Karin said, what is probably missing still is that we need kind of those international standards of what we think about, what we expect from those systems before we can really see a a lot of improvement.
So of course, when we speak about surveillance, we speak about AFI, and actually the same. AFI have different digital solutions that exist that are out already, and many countries have been asking that those solutions to be fully integrated within their HMIS system / DHIS2. So there is now a module both for the aggregate AFI that is anyway part of the aggregate coverage system that is already out, and there is a case AFI tracker or case-based tracker for the severe AFI cases that is out, and the country has started to use it as well. So it's also something to keep in mind.
Mm-hmm.
And after, wanted to go a bit beyond, because you know, for sure we mainly speak always about coverage data and surveillance, but there is more and more interest from the district manager to look at what we call the operational data. You know, about, do I have vaccinators? Do I have my stock of vaccine? Am I doing enough immunization sessions? You know, all those other elements that are anyway big piece of the day-to-day job of the district manager, and even of course the facility manager. And so there is out now several applications. So one is called the Scorecard app. You can look at the visual, and so there is a bottleneck analysis. And those applications, so they are based on the HMIS2 platform. They are out now. They've been piloting in some countries, so maybe some of you participants, you have experience, you can share at the end. And once the piloting will be successful, they can be available for any other country who want to try it. And another area is more and more linked between the CRVS system and the health information system. And for us within immunization is an important area, because we obviously see the baby just after the birth. So how can we make sure that both entities are winning? So we are trying to find for win-win solution. So what the EPI program can get in some countries, there is way more. I think Madagascar is one of those cases where you have the children are way more registered within the CRVS system than within the health information system. So if we can make sure that we communicate that list of children through the EPI program, and in many other settings, children get often the vaccine before the birth registration. So there is a possibility to connect those things in the DHIS2, for example, and soon in ComCare as well. And like that, it can help the CRVS to identify those children who are missing the birth notification. And the last piece is just to say we are going to talk at length, I think, on the last webinar on the what we call electronic immunization registry. So now we are not talking about aggregate mostly data, but really individual level data, patients that we can follow from birth or even from pregnancy to birth to all your immunization schedule and then continue to your life. But we just wanted to mention it that there is different WHO package on those tracker, and there is another. Okay, and so there is a DHIS2 solution for that, but in that area there is also a non-DHIS2 solution.
All right. So that was it, I think, for DHIS2. I think after this we can, well, first we have a few other slides that we want to show you to kind of stimulate the thinking, and then we want to encourage you to share your experience. So I see there's quite a lot of people with their hands up already. As we were talking, actually I was looking at the chat and I found one comment quite funny, and somebody said, I think Olivia mentioned that DHIS2 in some countries they look like a secret society because it's really hard to get account and access to the information. So this is one of the barriers that we talked about, and indeed the work is sometimes not easy. and long, but we wanted to give you, as last week, we had 12 ideas for improvement. This week we have only 5, so let's start with them. So first of all is to harmonize monitoring systems.
Yeah, so whatever system you want to use or you have to use, I think one of the priorities is to reduce the workload of all the health workers in the chain of information. So we really ask that you don't do duplications, that you don't record data elements 2 times, and you also avoid to do double reporting and double entry. We can see that, I mean, I've been in a country where immunization data is reported in 3 different systems, in the DVDMT, in HMIS, and also in the surveillance. Some countries have electronic surveillance system, but they also include coverage data. So 3 times is just too much work, and also it's just taking too much risk that those data will never align. After that, we also give you, try always to go back to the basis and make sure that all your forms, reports, database from your registry, telesheet, everything is aligned, that everyone has access to the definition and understands the definition. We also suggest that time to time you can challenge yourself and look at all the data we collect, I think, and try to see, how many times did you do an analysis of a specific data element. And very often we have a lot of data that we collect and that we don't really use, or we think we are going to use it, but in 2 or 3 years. So is it really, it's a hard price to pay. We're taking time from the health workers. During that time, they have, instead of filling forms, they could have been vaccinated more, for example. This came also, are you challenging all the desegregation that you have in country? We really suggest that now, check the maturity of your information system and check, which level of desegregation you want in link with the analysis you are going to do from those data elements. And also try really to do some linkage. We've been mentioning a lot of linkage between LMIS and HMIS. We can think about CRVS, of course the denominator, so the public statistics system. I mean, it's a lot of things, and you will see you have a much more powerful system if you got a good connection with other systems.
And if I may add to this slide, I think when I've been involved in kind of country efforts to make a data improvement plan or evaluate the data or kind of a DQS or whatever assessment there might be, I think one of the most useful things to start is actually just ask for the monthly report. To start from there, look at all the data and all the fields on that monthly report and try to find out where this data is actually used and how it gets entered and everything. And sometimes you find even that all the data that goes on the report is maybe it's not all entered even into DHIS2, or there's less data that needs to be entered, which is even worse, I guess. Or even if it's entered, you find that nothing ever happens with those data. There's no report, or it's not even presented in a dashboard or something. So in the end, people are not using that data, and in that case, as Karin said, we should challenge ourselves on whether either we should start using it or we should just drop it from the report, because everything that can be done to make the reporting lighter is probably a good thing.
And also checking your system, the decision you take now is not like definitive. We know that every 2 or 3 years anyway, they're going to review the data collection form. So you are always time to add more desegregation once you feel that everyone is comfortable. But it's like, we often do routine stuff, because we're used to that, but taking a bit of step back and challenging ourselves is key, and a suggestion for discussion.
All right. Next.
So yeah, it's a very important piece. Is actually, we have done a lot of work, all of us, in the information system to put data in, so in a paper or in Excel, in a system. But what do we do now to put the data out? And we really see, what can be helpful and which support can you have to make sure you use the data. We saw that setting up those dashboards that are meeting units, could be a good way of, easy way to analyze your trends, for example, or focus in certain area where performance could be dropping. So also, you know, seeing a very good performance and say, okay, I'm going to greet that facility manager for the progress last month. So those dashboards are very important and really making data more real and easier to analyze. So other things, and we talk a bit about more operational data, more support for managers. So some ideas are out, you know, it is our duty at the district level, you know, to go and support the facilities. So how do we do that? So there is some suggestions that even a facility does not have online or does not have internet, cannot follow up, you know, the progress they do. Sometimes the district managers, they can print at the district level their monitoring chart or the last report, and they can, when they go to supervision, they can give that feedback or bulletin type feedback to the facility. And this makes, you know, concrete, and the people working at the facility level, they can really see that all those numbers are becoming information, and they can have feedback on it. Then we have all those monthly validation or monthly review meetings that are happening within the immunization system. So there is a movement to also get them more standardized, you know, with more guidance on how to use those review meetings to get more output from all those meetings. So these are some ideas that could be explored, and you can give us some feedback at the end.
I would also say that indeed, like, there's more and more effort to kind of, for example, give mobile phones or use ODK applications to collect data. And I say, well, first of all, that's great, but let's also think about the use of that data and the data use culture. So to be honest, just an application to upload data is not good enough, right? It's not. It's only kind of to collect data and to hoover it away from that facility, but how do you bring it back to that facility? You really have to think about that.
So we talk on the desk review of the data quality, for example. So those apps, you may have seen on the previous slide, actually that app is the one with more installed in the country. It's more than 30 countries that are using it. It's already the second version, and another version is coming for district level. And it's something that people really like. You have a system of drilling down. You can see at the bottom of the picture, you see, oh, there is an outlier result here. Let me go and check, and you can, you know, really go down to the facility that may have been at the origin of that outlier. And this helps not just for the district manager to change the number, but just to contact that facility or to go in supervision and try to understand what is behind. And this, we have a lot of feedback from managers saying that, we noticed that a new nurse was sent to a facility. She was not properly trained, so we identified this quickly, and we went down for supervision, and this was sorted out. So it's a bit the power of digitalization, making those analyses much faster and accessible to everyone. So now is to use it for good purpose.
Yeah, also just to mention that one of the Gavi data quality requirements, for those of you who are aware of that, they have actually 4 requirements, and of course you all know what those are, but one of them is actually to do an annual desk review of your data. And just to say that within DHIS2 now there is a standard report that is actually something you can print out and use that for analysis. So that kind of supports or facilitates that analysis, which is also very useful.
And Jan mentioned at the beginning, we saw the first Mentimeter that you have many countries saying that you are now using only one integrated system. And the question came originally from those countries saying that, hey, we were used to pay our own EPI data managers, and now, you know, data are entered by other people, or those people have more time. What can we do with those persons? And it's really about this data in, data out. If you are, you know, you are spending less time putting the data in, it means that you have more time to get the best from the data and to use the data. So as a data manager, are now taking, I think, more enjoyable time to help preparing the district bulletin. Now many countries are doing district level EPI bulletin. They help on the analysis, on the visualization, they prepare some reports. So like that at the monthly review meeting, it is much meaningful to look at the data. They do also more time now for quality assurance, for example, tracking those outliers, saying, oh, what is happening in that facility, etc. So it's really giving more time for the quality of the data and for the use of it. So if you have that experience in your country, you can also tell us at the end.
Yeah, I think the trick here is that indeed, okay, now if you have HMIS focal point or HMIS data manager, so how can we really build a team and collaborate and have like some data professional helping with kind of making data available, and then, but it's still the program's duty to actually look at the data and see what it means for us to improve the program, because we can't rely on that for necessarily on HMIS. And have not HMIS, as kind of Olivia mentioned, have HMIS evolve into a secret society. So I think this is it for the presentation and kind of the lecture part of the webinar. So we are just about at 1 hour. I think, Alain, do you want to take it from here and facilitate the Q&A and maybe ask some people with their hands raised if they want to share an experience?
Yes, Bran and Karin, wonderful. That was really instructive, and I can see that there were a lot of interest from the attendees. You can see that in the chat box, we have many reflections coming out of the presentation, and we really touch it with explanation, really talk about what is really actual at the moment. And talking about the Q&A, we can see that Joma was the one who has like 20 votes. That's because you did a lot already by responding a lot of their questions. But we still have all Joma questions who took a lot of interest, and we can see that even Yaha, Mohammed, and Messi Latuka give some explanation. So I would like to add myself to say to you and Karen to give your insight about Yoma asking, I've used Open Data ODK mobile data collection application with CDC surveys in Ghana for measles and second year of life evaluation. I think ODK is a good application to ensure quality data collection. So the question is, can it be adopted for mobile data collection, especially in developing countries? Jan and Karin, over to you.
Okay, so Jan mentioned ODK is a system that is not used only within health. In any other system, it's a free application you can download in your smartphone, tablet, and it helps you to collect data. And it's quite easy to do your data collection form, and you can use it for anything. But it's really to bring the data in. Now there is a lot of limitation for visualization of those data or interpretation. So it's not done for that other aspect. So, and also there is some other application that can allow you to do the collection. Or for example, on the HMIS2, there is an Android app that has a function of data collection function in there. So, it's really free, easy to use. In every country, we'll find dozens of persons who can configure it. So it is out there, people can use it. Are we going, to make it, I don't know, mandatory to everyone? I don't think so, but it's out there.
Yeah, and I would add to that, I totally agree with Karin and what she said. Just to say that, it's a platform, so you can easily use it yourself. I think it's most useful for everything that is kind of a survey. So for example, if you do an MOV survey or even kind of a coverage evaluation survey, kind of thing, ODK is really good for that. I think in Apple there's also a experience of supported supervision, which is now actually being routinely captured on an ODK platform that is developed on top of ODK. So that is absolutely useful. It can for normal paper.
Thank you very much, Jan and Karin. I think that was awesome. So you did it. Before we invite really attendees to really use the questions that we have on the deck, making sure that they have this experience to share that with us, we would like you, Jan and Karin, is that possible, to turn on Tosif Alicia, who has got like 6 votes, but we think that the question, if you would like to ask to answer the question, he's addressing. Jan and Karin.
So to see if Alicia asks, in some epidemic countries, they are using very advanced systems for health data visualization, real-time dashboard, GIS mapping, but ground situation is opposite, which they are presenting. So the situation, how the advanced systems help in those decision making and how to identify gaps and problem in the systems as well on the ground. So I think that's a really good question. I would say, for example, we have a lot of kind of technology-based interventions. And I think if you say epidemic countries, I think it's often polio epidemic countries.
E1, I guess. E1, that's also
Worse, yeah. So yes, this true, and then yes, nothing but ground situation opposite to what they are getting. So I think what you're saying is maybe technology is not the solution to everything. It's not possible. That's just like I think also like I think that a lot of times kind of these GIS systems have been proven very useful for their own context and for polio eradication, for example. I think the next thing we need to think about is how can we as programs better use GIS mapping, for example, for kind of the basic routine tasks of micro planning, planning outreach sessions, these kind of things, making sure that all communities are included in the plan and in services.
Thank you. Thank you very much, Jan and Karin. And so I'm inviting everyone to get ready for the question. I can see that we have 8 hands raised, but I see that Patrick Martin has asked a question who has got 7 votes, and it's about how can we minimize the double reporting in information, health information system, and also enhance the proper utilization in regard to immunization program. Jan?
Yes, so minimize double reporting. First of all, it's often a question of the design of the system. If you're kind of several programs who each ask health workers to report the same data twice, then you're actually you're encouraging the double reporting. So I think this is mostly kind of a central level responsibility to really decide on one system and really kind of encourage the use of only that system. Enhance proper utilization in regard to immunization programs. So I think that might be, if what we mean is kind of that, okay, the HMIS system is not being used by the immunization program. Karin actually mentioned a lot of possibilities of why that might be, and I think that everything from the right data is not being collected. So, for example, we don't even have access to the system. So yeah, there might be different.
I think one of the aspects that is coming several times in the question is that so that you're asking that okay, the HMIS also take that data element to the EPI manager will develop, its own data collection form and feed it to the district. So we will have, consistently those parallel systems. I think it's, once you have challenged yourself, do I really need that data element? And yes, you do need it, and you know when you are going to use it. Now it's really most of the time a governance issue, and also awareness, how that DHIS2 secret society is working, for example, and how to bring immunization people to the table of HMIS and DHIS2. And in many countries, we saw a lot of movement since I'd say 2-3 years, and WHO is really powerful in helping immunization people to sit on the table of HMIS and saying those are the needs of EPI. Can you include that data element? What I would like to say is that we have done many countries have done a review of the DHIS2, for example, and they compare all the data elements that are recommended by WHO in that guideline and what is in the DHIS2. And you will not be surprised to know that we have an average like more than 90% of the data elements recommended by WHO that are already included in the DHIS2, and is way more than other programs like HIV, TB, malaria. So I think now the immunization program are able to fight for the data element. WHO can support and other partners can support that dialogue in country, and to say, you know, to make sure that when there is a next revision of the data collection form, the paper form, you know, at the facility level, you are at the table to discuss and put those elements. Within the platform, the DHIS2 platform is very easy to add one data element. The problem is that, you know, you need to review your paper form and print it again, so this is the costly part. And another element, you know, sometimes money helps governance, and once EPI manager say, okay, so far I had support to run my standalone immunization system, and what I was using as funding to make this run, now I stop that one and I contribute to the integrated HMIS system. And as soon as the EPI program was contributing just few percent of the overall cost, they also have their seat secured on the table, and they can push for the data element and all of that.
Okay, thank you, Jan. Thank you very much, Jan, and all the participants for their question. We would like to really hear from experience shared by attendees about the experience with the use of HMIS for immunization monitoring. So I will now turn myself to those who raised their hand, and I can see that we have Dana Sabe Usman, who was the first to raise his hand. So now, Dana Sabe, you are unmuted. You just have to click on your mic, and then we will be able to hear from you. And the questions are on the desk. Dana Sabe, good afternoon. Can you just unmute yourself, and the floor is yours. So while Dana Sabe is unmute, is finding his way on his mic, I will turn myself to Bala Saidu. Bala, good afternoon. Can you hear us? If you can hear us, please click on your mic to unmute it, and the floor is yours. Bala? And let us add Shinyere Blessing.
Hello.
Yes, hello.
Hello. Hello.
So start first with Dan Sabe. Dan Sabe, good afternoon. Can you hear us? Now we can hear you. Dan Sabe? So Dan Sabe is not.
Yes, I can hear you. Yeah.
So please go ahead. The floor is yours.
Yeah. If the air facility health worker providing into the data platform instead of submitting it level, I think that is my observation and contribution for that. Thank you.
Sorry, I didn't understand it. Could you repeat, Dana Sabe? Sorry, we didn't understand you. I think it was broken up.
Okay, I was saying that if the DHIS platform can also integrate it from the and collect their data, system data, and send it to the server of DHIS directly. If something can be done like that, I think it's going to be helpful.
Really sorry, you are breaking. We just
got the end. In the end, we could understand you, but in the beginning, not.
Did you send your question by writing?
Okay.
Blessing. So let us turn to Senior Blessing. If you can hear us, please just unmute your mic and the floor is yours. Senior. Senior Blessing, can you please unmute yourself? We will turn to Dr. Sidnalinga, HS. Can you hear us, Dr. Sidnalinga? You just have to.
Okay. Yeah.
unmute.
Thank you. Thank you very much. Actually, there were some like last slide. You were asking about the benefits and challenges of integration, so I think India we have a system called HMIS. I don't know whether it is exactly based on this DHIS 2 criteria, whether it is based on that. HMIS collects a lot of data, and I think it is very much useful if we have so much health-related data in one report, immunization data, birth data, and so many other types of data. And even we collect data related to AEFI in HMIS, that is adverse events following immunization in HMIS. So it is definitely beneficial, and for the purpose of analysis and for feedback and for for utilizing the data at the various level. But a lot of challenges are there, like for example training and collecting sources of preparing this data, sources of information, registers. Since there is a problem with registers at grassroots level, there is no integration among various programs of child health, maternal health. So then the data integration becomes difficult, and sending a report, probably there are some issues. And with respect to this EPI and HMIS, how this EPI can best utilize HMIS. I think HMIS is a very good platform. Integration is a good thing. So yeah, these are my. I just wanted to share these things. Thank you.
Thank you very much. I will now turn myself to Jan and Karim for their comment. Can you stay with us, Doctor, so that you can respond to their, if they have some clarification. Thank you. Jan?
Yeah, thank you. I think it was really a good experience to share with all the group, especially when it's a positive experience. So maybe if some other person are giving are talking about challenges, maybe we can ask them to connect and share what was good in the India experience for other challenge. But it's good to hear some positive feedback.
And from my point, I think your question, like you were not entirely, I think that in most states actually India is using DHIS2 for the HMIS, but not in all. I think apart from that, you also have a lot of kind of other systems around there. So I think, was it you who mentioned EVIN in the comment box? So you have the EVIN system that's actually based on Logistimo, which is kind of being integrated, or kind of like there's a link between that and the HMIS. Then there's also the MCTS, which is about the mother and child tracking system, which is kind of the beginning of an electronic immunization registry. It's not always clear how that works together with HMS. But yeah, there's a lot of kind of moving parts in India, and it still needs to come a little bit together, I guess.
I think they're independent systems, as I know. I think there may not be a linkage between MCTS and HMIS data, but they try to correlate at various meetings and other platforms. I think that linkage is not there, where a single platform with all this, just like as you mentioned for DHIS, there are different modules and the same login will we can just log into various different things, and there are linkages. I think that is not there between HMIS, MCTS, and even. So I'll find more about it. So thank you, sir. Thank you for your feedback and suggestions.
Thank you very much, Dr. Sidika. That was great to hear from your experience. Now we'll turn ourselves to Ota Kau. Good afternoon, Ota. The floor is yours.
Yeah, good afternoon. How are you?
I'm fine, thank you. And you?
Thank you. I'm very well.
Great. So the floor is yours for the experience.
Thank you. I am working in Nigeria for UNICEF supply chain and logistics. So using the DHIS tool is paramount important, and it's really the beneficial data tool for all the implementation managers. My advice is not only using the DHIS tool for uploading the data, but really want to encourage the other colleagues to start using the data for action. For example, in DHIS2, you can see the coverage, the wastage rate, the population census data. So most of the time, the other field colleagues, they use this data for only uploading reporting. But I'm thinking the only solution for us is to use this data for action. You have the data offline, online, you download the data, but not only for presentation purpose, we have to use this data for action. Meanwhile, I want to advise again for using the DHIS2. There are some challenge area for the data element under the immunization available data. If you can look at it, now that we were advised to move out from the DBDMT using to the DHIS2, which is very important. But there are some element data that are missing, like the IPV data. If you want to get the IPV data to analyze your report or to upload, whatever you want to do for IPV data, you have to go to supplemental immunization data, of which some of the other colleagues have limited on this section. I want the DHIS2 team to upgrade this, as we have the remaining antigens for Nigeria. The 9 antigens were already there. So why can't they upload again to update it with the routine validation data for IPV to be uploaded on this software? This will really help the system. That's my advice and for the team and for the high-level officers to upload the data too. Thank you.
Yeah. Thank you, Ota. Can you please stay with us? We will turn ourselves to Jan and Karim to hear the comment about your presentation.
No problem. You're welcome.
So thank you very much, Ota, for you to have shared your experience. And indeed, you know, it's really the idea that those digital systems help us to better visualize the data and then better use it for action. As you say, it's a very nice you know, experience to have shared that. Regarding your question, so if you have a data element that is missing, there is technically, in general, no issue with the platforms that have thousands of data elements. So to add one more is in general feasible. So now it's a question of you know, linking with the HMIS group or the DHIS2 team to see when they have scheduled, because you know, you cannot go every week or every month and one program will say I need that and that. So in general, they have a timing and they will tell you, okay, in December we are going to review this year, for example. So every program has to come you know, with the data elements they want to add, but also what they want to remove, because they've been through that challenge process and they review all the data elements. They update it as they go to the HMIS program and they ask this to be integrated. As I said, within the IT system is not that complex. It's more, you know, every other steps that are out, you know, so because those elements are coming from a tally sheet, remember from the health worker who have been giving that IPV vaccine, then he has to put it in a tally sheet, in the register, etc. So we have to update all those tools, and this takes time. So it's why what they do is that, you know, periodic schedule, every year, every 2 years, it depends on the country, and you process, and then you have to be part of that, and keeping the good relationship, it should be fine.
So I think on that note, for me, there's two possibilities, and often you go to countries and they say, well, they haven't even introduced IPV yet, for example. IPV is a good example. Now, I think there's two possibilities. Either the program asked them to include it and they didn't want to answer to your email, or the other possibility is that actually the program knew that IPV was coming from years in advance, but actually nobody told the HMIS people. And we also have to acknowledge that kind of changes in the system. It's not just the platform that needs to be changed. You have to probably reprint tally sheets, registers, home-based records, all these things. So it's something that requires a lot of, it requires some time in advance for planning that change. So we also have to be knowledgeable about that. Of course, in Nigeria, as you say, still in the process of migrating from kind of one to the other platform. And I think with that migration also come the lessons that we're learning now, I guess, or that you're learning now, that all of these things need to be carefully planned, and you need kind of probably like a governance committee and a design committee that really kind of sits together every quarter and says, okay, what do we need to change or whatever that is. Normally, I think the updates are every 2 years or something in most countries.
Yeah, it all depends. I've seen some countries every year. Actually, it's before launching the RFP for printing in general, like 3 months before they review, they ask also program, what has to be removed, what has to be added. And also, you know, country more now they're testing those forms in the field, so it could be 3 to 6 months before the launch of the call for the printing. But we have countries, I think I remember in Ghana, for example, I don't know if some people from Ghana are there, you know, where everything is there is a SOP and a protocol, and everyone have access to that, and they know, you know, the periodicity when this is going to be reviewed. They know who is sitting in that committee. You know, everything is there, and now it's clear, and EPI can be, you know, fully on board and aware of that process.
And the other point that I think quickly, because I think it's important, kind of the use of data. Absolutely, that's the most important thing. I would say, like, instead of like saying that okay, people don't use data, we should kind of take this one step at a time and do it simply. We should say kind of, if your HMIS says X, then the actions should be A or B or C. Not just say, well, they should use the data, but really try to work with people to say how we can use it, what actions need to be taken if they see, for example, high wastage or whatever that is, or maybe many stockouts or logistics data. So, but I agree with you also that that's the most important thing.
Thank you very much, Ota, and thank you, Jan and Karim. That was awesome. So we hear a lot. Thank you, Ota, and I know that you are happy. You're happy with the answers, the suggestion of our expert. So before we start wrapping up. 7 minutes remaining before we stop the session. But I would like to hear from one experience again, the one from Gloria Nabanado. Gloria, I just unmute you. If you click on your mic, you will be able to hear you. Gloria, good afternoon. Gloria, if Gloria cannot talk to us, I would like to send myself to Angel Oti. Angel Oti, good afternoon. Can you hear us? If you can hear, just unmute your mic. And now Chinere Blessings, the first one to be able to talk to us. Chinere Blessing, good afternoon. You're also unmuted. So if you can click on your mic, we will be able to hear from you. So unfortunately, none of them. So we invite Tosif Ali. Tosif has his question answered earlier, but he would like to talk about more. So Tosif Ali Shah, can you hear me? If you can hear me, just unmute yourself. The floor is yours. Tosif? And what about Yonwil Jakian? Yonwil Jakian, good afternoon. Can you hear us? Yonwul? And we also try Samuel Maloga. Samuel Maloga, good afternoon. Can you hear us?
Yes, I can hear you.
Right, Samuel. Yes, you were breaking up, but it's okay. The floor is yours. We remain only 5 minutes, so please share your experience with us.
Yes, with me, my experience that I've been having with the EPI system is that, you know, sometimes data will be collected on the field, but we only get the aggregate data at the end of the month. But sometimes you may not be able to know whether what has been submitted is right or not. So in order for the integration process to be very effective, I would suggest that if there could be an app that's on the real-time collection of data, people can be using that app so that they'll be reporting directly into the DHIS tool. And then at the end of it, we can see that this is truly what is being collected from the field. And in addition to maybe the GPS coordinates that can be uploaded direct from where the service is being delivered. And that one will really help that the data that we'll be collecting will be very reliable for decision making. That's one of the things that I want to say. And then apart from that, too, sometimes you see that the apps that the forms that are developed, sometimes at a point in time, the form will be changed from from what is existing in the DHIS2, but what is on the grounds is not being changed. And that one, the officers that are in charge of those data, they may not be able to know what is currently pertaining. So you would suggest that at least when those things should always be made available on the DHIS2, so that when there's a change, it should also be on the DHIS2. So that when you download it, you'll be able to reflect exactly what it is. To help make sure that there is improvement in the data quality and in the system. That's
Yeah,
the little
thank you.
experience that I would like.
Thank you for sharing your experience, Samuel. That was really interesting to hear from you. I will now turn myself to Jan and Karim for their last comment, 3 minutes before we end up that interesting and instructive session that we all enjoy. So please, Jan and Karim.
Thank you, Samuel, for your question and comments. I'm sorry I didn't hear all, but what I understood, I think you were asking about the digitalization or data entry from the ground, from the field, from the service, for example. And indeed, and there is more and more countries now that have laptop or tablet or smartphone in every health facilities. So indeed, there is more and more facility who are entering their data directly at the facility level, and they are not sending a form to the district for data entry from the district. So this is indeed a real progress in one way. Some people are saying that the quality of the data is better, because it's really entered from the level of production. And also, there's more movement now for increasing dashboard or tools to use that data straight from the facility. And it's interesting because it's not the same things you are going to look from a district level or from the facility level. So indeed, this is the way forward, I think, and we know that within a couple of years, majority of the country will be at that level, and is interesting. This is what I got from the first part. I don't know, Jan, if you got the second part.
Quickly, maybe adding that you also mentioned the app for real-time reporting. So it's actually like an interesting idea that people have been exploring that. So if you have the paper-based report at the end of the month, so you have to keep all the administration at the end of the month, make your report. So some people have been exploring also the use of like an electronic tally sheet, for example, where you can just do a session at the end of the session, directly report whatever the tally sheet says, and that goes into the HIS2. So that's indeed a possibility. I think it needs to be explored. I just want to be mindful that a lot of people also in the chat, and I'm reading your chats and questions and answers also, a lot of people have raised the problems of human resources at the lowest level and kind of really at that health facility level. So I agree with Karin that many countries will be in a position in a few years to actually have like electronic entry at the lowest level, but not all countries are there or will be there in a few years. So we have to be also very pragmatic about how far and how fast we can go with that. I would also say kind of electronic reporting shouldn't always be about more reporting. Sometimes it should be about less reporting, not overwork people in what we kind of ask them to report. I think really focus on the basics like the vaccinations that are being administered, not too many disaggregations, and then maybe some specific things about the logistics, for example, whether there was stockouts, vaccines used, maybe all these kind of things, but really keep it as simple as possible, and I think that's really the key to success for a lot of this. And I also don't know if I kind of heard your entire question, but I think we need to round up the webinar anyway. I just have been projecting the topic for the next webinar, which is on November 6th, which is on everybody's favorite topic, denominators and target population and target setting. So we will actually, it's to be confirmed, but I hope we will have Mamadou Diallo from UNICEF, Carolina Danovara, who you know from WHO, and myself, and we will talk about the denominator problems, and we'll do a deep dive in geographical information systems. And for that, we will also have another person from UNICEF, Rocco Pansieri, who will come and talk about how we can use geographical information systems and satellite imagery, for example, to identify missed populations and to kind of make sure our denominator is complete and we cover everybody. With that, I would really like to thank also Karine for coming over here and being with us together for this really interesting webinar again. I would like to thank you for the participation. You're always very interactive and you show a lot of interest and questions, so that's great. We'll try to read all the questions and try to, at least in some next webinar, trying to answer some of those. And also like thanks to Alain and the Scholar team for actually facilitating this webinar. So thank you a lot and have a nice afternoon.
Thank you.
Bye-bye.
Bye-bye.
Bye.